Hero of Health, our weekly live health show where we interview health heroes who transform their own, their patients, and/or their community's health. And today's week's hero of health is Dr. Kiran Agarwal. And today we are going to tackle the topic how to treat sleep apnea. Now, we are a group of NHS doctors on a mission to empower 1 million people to reverse their chronic diseases and tackle loneliness. To achieve this, we build lasting communities where we deliver the coaching and health education one needs to become a hero of their own and their community's health, regardless of their socioeconomic background. You can join our Health Walks community coaching and education to become the hero of your own health by joining us on our website, heroofhealth.com. And you can also become a member free of charge to join the peer-to-peer support you need to tackle your health conditions. Now, today we are talking to Dr. Kiran Agarwal, who works in London as a family medicine doctor, GP, and also specialist in ENT. She is passionate about finding the right solution for the individual and does not believe in one-size-fits-all approach. She uses combination of lifestyle integrated interventions along with modern medicine to personalize the treatment plans. Her patients love her for non-judgmental, comprehensive, and holistic approach. Because of her vast experience in ENT, she yearned this discipline to get the missing spotlight of lifestyle interventions. As they are not well known, this led to her journey of finding lifestyle solutions for ENT issues, and she has come across so many evidence-based solutions which will make lives of these patients much better with less medications and less surgery. Thank you so much for joining us today, Kiran. It's amazing to have you and to spread the lifestyle medicine message.
Thank you, Linda. And thank you for the introduction. And also, I'm grateful to you for giving me this opportunity, this platform to spread the message. I must admit, this is my first talk on subject like this, and I have got a lot of courage to be here because I'm not a normal speaker or anything like that. But I felt strongly, especially, with your energy and with the way you're spreading the message, that there is missing pieces of information we have to share with our patients, with our fellow health professionals, which will, in my view, transform their lives. So I'm hoping that I'm able to share that today. I understand we're talking about sleep apnea, obstructive sleep apnea to be precise. I'm happy to share what I have learned. I just want to make sure that people understand that this is all from my own learning and a little bit of experiences with patients, because at the moment we're still struggling with getting these solutions into NHS. But I think that shouldn't hold us back to share this so that people can get the help from other sources. So thank you.
Absolutely. Thank you very much for joining us today. You are very humbled about your experiences, but I know too well that you have had a vast amount of experience in ENT and in GP, and that's why I'm so excited to bring your message, because we really are lacking the lifestyle message in all the subjects. But more and more we are bringing into our current NHS treatment, but there is a little bit more lacking. So that's where we are trying to kind of bridge the gap here. So we are speaking about sleeping and sleep apnea today, a subject that is actually really distressing to our patients. Could we start to have a look at, in general, what is sleep apnea and why do you think it's so important that we look at the lifestyle aspect of it?
Sure. So just to kind of clarify what sleep apnea is. So it's a conglomeration of different sleep-related breathing problems we're discussing where there is disordered breathing during sleep. But being an ENT, I focus on the obstructive sleep apnea because that's what, as an ENT professional, we get to find the level of obstruction and to help understand how do we alleviate that obstruction so that the problem can be helped. So obstructive sleep apnea essentially is a disorder of sleep where the person is sleeping and their airway is getting obstructed. Now, it's not as simple as that. that you're sleeping and your airway is obstructed, and it's not like any other sleep issue, like you can't sleep, insomnia and things like that. Here there is a medical problem, because when your sleep is obstructed because of the breathing issue, you're not just waking up a million times a night and it's fragmenting your sleep and causing all those sleep disruptions, but the hypoxia means lack in oxygen. So the reason why you are getting the problem of apneas is because apnea means where you can't breathe. So say you are breathing from your nose, and that goes into the back of your throat, and then down to your airways, and then to your lungs, and oxygen exchange happens. Now somewhere here, there is airway obstruction. What it does, it causes the oxygen levels to drop. When that oxygen levels drop, it causes your heart to to get less oxygen. That means it goes into different rhythms. So we find arrhythmias of the heart in these patients more commonly. Other thing is that it increases the pressure inside the thorax, because there is messages, there's signals going on inside the body. There's something wrong. We're not getting enough oxygen. Remember, oxygen is the life. So when you're sleeping and you're not getting oxygen, that essentially means that you are constantly trying to go for it. So one of the ways the body tries to compensate is by waking up. So you're getting those, arousals, and that's what happens. So when the person is sleeping, we find that they are choking, they are waking up frequently. People around them are noticing they have movements. They are finding that they're obviously loud snorers. People who have sleep apneas, they usually snore loudly because of the obstruction. And then these are additional things. So, on the surface, it looks like, okay, well, obstructive sleep apnea, essentially what it means is that there's an obstruction, there's a sleep problem, but it is downstream effects of that problem leading to other issues for your general health. And it doesn't stop there. We can go on and on, but I don't know how much deeper we have to go in today.
No, that's a really good explanation, that there is a problem that is organic, and we have to look at that more in detail with especially the expert, let it be in the NHS or anywhere worldwide with your specialist doctor. But then there are things that we can do within sleep apnea that we can improve on this obstruction. Is that correct?
So there are multiple things. So first, I think we always have to understand the problem. We have to understand the magnitude as well as the impact of the problem on ourselves. And this is a problem which unfortunately is not an individual's issue. So say, for example, you're diabetic, or you have a stroke, or you have, something like polycystic ovarian disease. You are the person who is having the problem, but with sleep apnea, the partners suffer, the families suffer, and also the communities suffer, because the person can be driving without knowing that. So one of the challenges is that if they're not getting the assessment, they're driving with sleep apnea, causing accidents and things. So there are, when you look at the wider impact of this issue, it's huge. Apart from that, if I told you what the global disease burden is, actually was looking at the Lancet paper from 2019, which highlights the global burden of obstructive sleep apnea. It says 1 billion people are estimated to have obstructive sleep apnea. That means 1 in 8 people. That's huge, isn't it? So
that is huge. 1 in 8 people worldwide are suffering from sleep apnea.
And that's Lancet report. We're not talking about any rubbish journal or anything like that. So that's an estimation. Obviously, we don't know whether it's more or less, but these are big numbers. So we have to
really big numbers. And currently, what is the treatment choice for sleep apnea that is most commonly advised to your patients when they see their specialist in the NHS?
So what happens is that first they come to their GP in UK, or the partner asks them to come, like, he's snoring and I'm noticing some breathing pauses or some trouble, or they are also noticing, the person themselves, they're also noticing that they are fatigued during the day, they're tired. It takes a long time to realize that there is an issue. It takes up to a year to 2 years sometimes for some people to recognize that there is a problem, because it's not so obvious. It's happening in the night hours, okay? So it's not like, okay, well, oh, you have got a broken ankle or you have got a heart attack. It takes time for these problems to be recognized. So time is already lost because the body has changed, body's physiology changes in that time. So the partner or the patient is noticing some issues. It's impacting on their kind of bedtime and how they're both sleeping. For the patient or for the person who's suffering from sleep apnea, they are noticing things like daytime, they're fatigued, they are falling asleep if they're not stimulated, things very easily. They also can get morning headaches. We don't pay attention to morning headache that much. Once the neurologist has seen and they've said there's no brain tumor, things like that, but they can get very serious morning headaches, dry mouth, and all those simple things which do not kind of amount to too much. But then when you put the whole picture together, then they are coming to the doctor, and it depends again, who is seeing you, and then you are referred to a sleep medicine specialist. We do some questionnaires like Epworth Sleepiness Scale or Stop Bank questionnaires to see if you're higher risk. But unfortunately, if you look at the clinical assessments, about 50% we can miss. So we cannot just rely on the clinical assessment. If there's a suspicion, I always say we have to refer to the patient to a sleep clinic. And once they're referred to a sleep clinic, they go through their assessments. The assessments are more, detailed. They get more. The gold standard for diagnosis is essentially sleep study. Now, sleep studies can be done in the sleep lab, or it can be done at home. They're different, protocols. I think the home sleep study is becoming more popular because it's quicker to do. You don't have to be in the hospital. But if it is not showing the results which we're expecting, or there's some doubt, then they are transferred to the sleep labs and things. So the test that you go through is more detailed, is polysomnography, where they're checking the oxygen saturations, they're checking the ECGs and the brainwaves, and that's very technical. I just get a report that, okay, these are the things. So the way it's measured is like how many apneas and hypopneas they're getting per hour. So apneas means when they stop breathing, and hypopneas when there's a reduction of oxygen level of up to 30%. And then we calculate how many times an hour, because if they're more than 5 an hour, up to 5 an hour can be normal, then that's diagnosis leads to more formally accepted. So unfortunately, it's a long process, Linda, that people have to go through when they're suspicious of the problem.
It does sound like a really, really long process. And as you said, there's quite a lot of physiological changes that are already happening while we don't know about it yet. We haven't picked up that you yourself or your partner, listener, is having sleep apnea, but we are already having physiological changes in our bodies. And then we still need to pick it up, maybe by talking about it and understanding the symptoms and signs. And then we have to get into the system, and it might take a few months before we are actually officially diagnosed with it.
That's correct. Yeah.
So how do we empower our listeners to, if they have an idea that maybe something is happening at night, what are the symptoms and signs they should be looking out for?
So the commonest thing is snoring. If a person is snoring loudly, and one of the common thing to get it, that person is having a very good sleep, or they're annoying us. That's not how we should be visualizing snorers. Yes, snoring is mild a lot of the time, but as I said, the estimates for having sleep apnea is 1 billion worldwide. So 1 in 7 or 1 in 8 people at the moment may have this condition. So we have to be mindful, the first immediate, that it's a loud snoring. If you notice that, then you should pay attention to their breathing, like, if you're the partner or the spouse. And yes, I forgot, I'm so sorry, it can happen in children as well. So if you're a parent, you have to understand that snoring is not normal for children. And then you notice their breathing. How are they breathing? Are there any pauses? And also look at the daytime functioning of the child or the adult. So commonly in adults, it will be that they are lacking in energy, they're tired, they're falling asleep more easily. It depends upon, again, it's mild or severe. It's a spectrum. It's not just one thing. And in children, it's very interesting. In children, it presents more commonly as attention problems, behavioral problems, developmental issues. So it's put down to as a naughty child. And there was some code I was reading in my textbook one day. It used to be seen as a disorder of the stupid children. Do you see what I mean? So because their behavior is different, because they're lacking in sleep at night and that's not refreshing them, so their attention span, their behavior, the development becomes different.
This is fascinating, Kiran. This is not something we talk about every single day, that's for sure. And certainly we don't talk about kids possibly having sleep apnea. We very often think about patients, usually male, who are overweight, maybe already developed metabolic syndrome. And so they're going down the line of a weight-related obstruction to the throat. And this is how we kind of visualize it as a syndrome. But you're saying that kids can have it, and that we should be picking up on this. And what are the signs that our parents and their parents should be looking out for?
So the parents are checking if their kids are snoring loudly. So it's not normal for a kid to snore loudly and not ignore that. And what if they have attention or behavioral problems and things like that during the day? The children one is a little bit easier. So if you spot it, the most common reason for obstruction is large adenoids and large tonsils. So their obstruction is much more visible. In adults, it's slightly different picture, and we can talk about it later. But if you focus on the kids for now, so when you go to a doctor and say, okay, my kid is snoring or there's a problem, if you just looked inside the throat and if you find big tonsils, so the obstruction is visible. Now, when you can see that, they have to refer to the right, usually an ENT, and ENT will then refer to sleep studies and stuff after looking at the whole picture. And adenoids can be seen on x-rays. We don't even need to do endoscopies for kids, because that's one of the other things which we do for assessment of sleep apnea in adults. So once you get a picture of where the obstruction is, which is much higher up in kids, then you remove them and it goes back to normal.
Sorry, what are adenoids for those who don't know?
I'm sorry. So we're all familiar with tonsils. So tonsils are the ones which sit in the throat, and so throat, who hasn't had one, and adenoids are tonsils at the back of the nose. So it's another pocket of lymph tissue which is sitting back of the throat. So like your tonsils can get big, the adenoids can get big as well. And because it's back of the nose, that's where it can cause obstruction.
Right. So even in children, those who are more mouth breathers, unfortunately, we have to highlight here that you shouldn't, if your child is mouth breathing, we need to train them, isn't it, to get them to nasal breathing, which is much harder. Even in adults, it's hard, but in kids, it's even harder. But we are saying, even if they are correctly breathing through their nose in and through their nose out, even then there can be an obstruction because it's higher up through the adenoids.
So you're absolutely right. So one of the reasons why they are breathing from the mouth could be that they are blocked from the back of the nose.
Right.
So that's a very good point, Linda, that if they have got that mouth breathing pattern, and they may have a little nasal intonation of the voice as well, like because the nose is blocked at the back, and those are the clues. I remember when I was my first year ENT, and this is just a story which came to me from what you said. And one of my cousins was sitting, we were just chatting around. She was a younger one, probably more young than she should be for being a cousin. And I was like, I think you've got adenoids. And she just her mum was very cross with me, but anyway, because you learn these things and you start looking at when you can look. And she had adenoids, and she had to have adenoidectomy, and she was having sleep apnea. So these things are
wow, come on, this is so cool. This is amazing. You just like picked it up on the go, and you really saved her so much suffering. And, you corrected her breathing just through picking it up. And that's the power of a little bit of knowledge around this topic, right? That we can make such a huge difference to children's lives, particularly if we pick up on this early on. And we kind of also have to say, we have to push for it with our specialists, right, in the NHS, to really have a look at that, because we kind of underestimate sometimes the importance of the correct breathing.
Oh yeah, definitely. Well, I mean, that was lucky, and she's still thankful to me.
I would be definitely too.
No. So I think the first point, again, with everything, I feel, is awareness. If you do not know, then you do not know, and you're not looking for it. Once you start knowing, I'm not saying all problems are because of this, but we should consider this as an issue. And I think, problem with tonsils and adenoids in kids are more commonly known. Maybe not so much in the layman circles, but in doctors, I think they are more aware of it. So if your child is mouth breathing, snoring, if your child is having problems with attention behavior, and they have had all the usual, because normally what happens, they're brought to the GPs, they get the ears checked, they get the hearing checked, they get the eyes checked, there is a checklist of things. But one thing which we probably should add to the checklist is looking inside the throats as well.
And besides the adenoids, what other is there any other obstruction for children that we should be looking out for with regards to sleep apnea?
So adenoids and tonsils, as far as I know, is the commonest. Obviously, if they're syndromic children, so if they are children with so I don't want to complicate by giving medical terms. So if they have anomaly of the face, because we're talking about the airflow in this area. So if there is micrognathia, retrognathia, if the jaw is not well formed, if they have got things like hypotonia, which probably is common in patients with cleft palate, Down syndrome, where the tone of the muscles is less and the airways are more floppy when you sleep. So those children are at higher risk of having these. But I think because of their special category, they do get checked for these things in general. It's the more normal children where we don't suspect these problems, where we're not so much aware, we have a higher chance of missing. But in terms of other causes, are usually either problem with the growth and development in the bones around the airway or the jaw, and if there is a disorder where there can be loss of tone of the muscles, if that makes any sense.
Mm-hmm. Yes.
I'm trying to deliberately avoid medical terms.
Perfect. Yes, I think it's very clear. We are looking for asymmetry in the face, asymmetry in the back, which we can hear through snoring, I think, and through maybe patients with asthma and dysfunctional breathing. Always consider is there an obstruction, and if it is lasting maybe longer than a few weeks, months, make sure that you get it checked out by a specialist and ask specifically, right, if could they have an adenoid or a tonsil problem, because yes, sleep apnea is an issue and it can really affect their brain development, because oxygenation is poor to the brain. On the long run, it can be devastating if it's not treated. Is that a fair summary?
Yes, and there is a mistaken diagnosis of ADHD in these children.
Okay.
So because they're having attention problems, concentration problems, they can be labeled as ADHD when actually their sleep is poor because of the obstruction. So
okay. And so what can we do practically besides just referring the patients and waiting for the referral to a specialist? Is there anything we could do or for the children to improve on this breathing?
I mean, because this obstruction is more anatomical, it's difficult. If they've got really, really large adenoids and tonsils, yes, you should do all the normal things which we talk about. But because the obstruction is there, it's harder to say do this and do that. And because I don't want to demotivate people either, because they feel they may be doing something's not working, but because there's a real obstruction in the airway, unless that's removed, it is really difficult.
Let's have a look at sleep apnea and its presentation in adults then.
Yeah. So adults is a completely different picture. So in adults, it's much more complex in terms of how it presents and how it involves the rest of the body. Um, Before I go into the different ways it can manifest in adults, if I just said a few points about the impact it can have on the general health. So did you know that obstructive sleep apnea is an independent risk factor for stroke? So you can get the diabetes corrected, the blood pressure corrected, the cholesterol fine, but if the sleep apnea, obstructive sleep apnea is not treated, the risk factor of stroke is still there. It's an independent risk factor.
Gosh, I did not know that.
No,
That's fascinating.
and I, as an ENT person, did not know it. It was more about me trying to find out, oh, now I'm a GP. Now I need to know more about strokes. You don't learn about strokes as an ENT that much. But and then putting the lifestyle lens on, I'm like, my God, we are not serving these patients well. We have to tell them their risk factors. It's not just about having some problems with sleep and obstruction. It's more widespread in their body. So it's an independent risk factor for stroke. It's a risk factor for atrial fibrillation. It's a risk factor for ischemic heart disease. All the metabolic syndromes we talk about. If the sleep apnea, obstructive sleep apnea, is not treated properly, you cannot get those numbers right just by lifestyle.
And just for those who are listening and don't quite understand the term, the independent risk factor, what does that mean?
So, for example, if we are, you might have gone to your GPs, or you might know somebody has gone to their doctors who have had the blood test done or blood pressure checked. You will find that you go to a list of question answers. Are you a smoker? Are you drink alcohol? How old are you? So those are risk factors for those conditions like heart attacks and strokes. And obstructive sleep apnea is independent of all of that. So even if you corrected the blood pressure and if you corrected the sugar levels, your computer is saying, fine, great, but if you haven't corrected obstructive sleep apnea, the risk is still increased. It doesn't make sense?
Absolutely. And so if we would put sleep apnea into your calculations, would that be better?
I mean, I'm not a statistician. I do not know how these risk calculators, how they work. But obviously, if somebody has got obstructive sleep apnea, then I do mention that there are more risks than they think they have of the general health. That includes heart and brain and all the other organs as well.
And as doctors, we just have to keep it in mind that, yes, we need to ask about sleep apnea and snoring. I think very often we talk about it as a distressing thing in the family, but also we laugh it off and, yeah, of course he's snoring, they make jokes about it, but actually we need to take it really very seriously and ask the right question about it. How long has it been going on, and has it been checked out by a specialist to make sure that this isn't linked to an organic obstruction, right?
Yeah, and as a partner, as a spouse, pay attention to the breathing when they're sleeping, snoring. Are they breathing pauses? Are they choking? Are they gasping? One of the other things which may be helpful, where there's a condition, and I don't want to confuse people, but it's called upper airway resistance syndrome. It happens in tall, thin individuals. So these are away from those, the type we have discussed, people who have got higher weights and stuff. So if somebody's sleeping with the how I say, like if they face up, like facing towards sky, they're hyperextending the neck because they're trying to get the air through the airway at the back. So if they're noticing that kind of posture where they're sleeping facing and extending the neck, that's another soft sign to look to. I think snoring covers a lot of the things, because that, don't ignore it. The message is, just don't think, they're having a good sleep, but they're annoying me. No, they may be having problems. And as a partner, as a spouse, just be a little bit more caring in terms of noticing what they could be going through.
And are there any other risk factors associated besides stroke with sleep apnea?
So it is a risk factor for stroke. So it's a risk factor for other conditions, all of the metabolic diseases, diabetes, blood pressure, cholesterol, ischemic heart disease, heart failure, all of these things. they do not get better. I have a cardiologist colleague, and we continuously talk about how their patients with atrial fibrillation is lifestyle. I'm like, hey, yay, you know, and how obstructive sleep apnea is closely related to atrial fibrillation. You know, as doctors, we don't even think about atrial fibrillation being linked to the sleep.
Very often we visualize it as sleep apnea as a side effect of all of these metabolic diseases, but let's be speaking about how sleep apnea can actually be a trigger for these diseases.
So the way I think about this, it starts as obstruction in the airway, but then it has got downstream effects. So yes,
literally.
Yeah, and then obviously the obstruction starts because of various reasons. And I'm sorry, I haven't answered the question yet of the different types in adults. So the most common type, as you had initially described, that you know somebody's overweight or obese, or you know having other risks like diabetes and blood pressure, because that comes in hand with the metabolic issues, the weight, and all the stuff. But it's different in males and females as well. In females, it's more subtle. And one of the things I realized that actually most of the research in obstructive sleep apnea, and actually reading more about research articles, it's obvious that most of the research is done in male participants or done by male doctors, and their focus is slightly different. And the subtle manifestations of sleep apnea in females are not taken care of. So what do I mean by that? So in females, it may not present as loud snoring that much. It may present with morning headaches and feeling fatigued and feeling tired and dry mouth waking up. And you're thinking, oh, well, oh, she's menopausal or whatever, and those things. And actually, it could be a problem with sleep. It could be even a problem of obstruction during sleep. So those subtle things are missed because they are not widely spoken about, because the male pattern of sleep apnea is more loud, I say. Other thing is the younger patients and the older patients, they're slightly different. So if somebody is young, I say they're at higher risk of the other conditions which we already spoke about. So if somebody is young, obviously, you know, compared to somebody who is older, the risk is less. So, you know, in terms of managing the patient, those are things which we have to think about, like, okay, well, this person is in this category. So currently, you know, what we were talking in the beginning, like what happens? You go to your doctor, they do an assessment, and they send you to sleep clinic, and they have a sleep study, and then you're put on some treatment, and we'll talk about that in a second. But my view is that instead of doing sleep studies and then putting you on treatment, we have to look at these things. Is this person, what's the age of this person? What's the gender of this person? What are the additional symptoms? Because then you can target the treatment a much more, you know, individualized, personalized way. Because what happens is then when the treatment doesn't work, then you go back and look at, oh, why it didn't work? But I think we have to stop that, you know, cycle. Am I making any sense?
Absolutely. It's I love the fact that you have brought on the issue of 8 children, then we went into adults, and now within adults we divided into men and women. Unfortunately, we know too well that medicine is very patriarchal, and a lot of the diseases actually were studied by men on men for over centuries. Well, since the beginning of Aristotle, philosophy and students of philosophy, they were conversations between men for men. And this is a fact that is really underestimated in how it affects our treatment. And I love that you brought it up on how it presents in women, because yes, they are more quiet in the presentation. And also misdiagnosis in multiple diseases is very, very common. So just one more time to sum up, if you are a female.
I'm sorry, Lynn, just one more thing. In the female bracket, the other thing which presents is that what we forget is that they also have other sleep problems like chronic insomnia. So, you know, multiple sleep problems can coexist in the same person. So if we don't understand this, because for some reason, we can talk about some other day, women have more chance of chronic insomnia. and that coexist with obstructive sleep apnea. And just having that understanding that we have to look into that as well. We have to not only treat the obstruction, but we have to treat the insomnia element as well is important, because then otherwise you can't figure out why things are not working. Is it any?
Yeah, so with regards to women, the summary that we are looking for that is less common are, if we can do a few bullet points for them.
So it may not present as loud snoring, although they can snore, but it may present slightly differently in the form of that they're more tired, they're fatigued, they have morning headaches, they wake up with dry mouth, they have got all the other kind of diseases. It's possible diabetes, blood pressure, high cholesterol, one or all of them, heart diseases, and diabetes and blood pressure. So it's just kind of the features may be more subtle.
And when the features are so subtle, how do they get through to a specialist? Because we are measuring these presentations based on, as we mentioned, a more patriarchal assessment. So is there anything that we can say to the GP or specialist to consider them for an assessment of sleep apnea?
So tiredness is a very common presentation in GP land. I probably would say half of the clinics are filled with people who have come to see us because they feel tired all the time. So one of the things which I ask is sleep. And I'm not saying every person who's got a sleep problem has got sleep apnea, but if you have done the more obvious medical, you've ruled out the cancers, you've ruled out the obvious medical issues like thyroid and all that stuff, and you're left with nothing, and patient is genuinely tired, then we have to just look at the sleep, and also depending upon a few other questions which we have already discussed, we ask, and then maybe send them for sleep studies. That's the approach I use.
That's very useful. Thank you. And now if we have a look at from when we are diagnosed with obstructive sleep apnea and the specialist started the patient on the current treatment guidelines, what are the treatments that commonly you get from the NHS, and how could we supplement it with lifestyle?
Thank you, Linda. That's my favorite question. So in terms of the current, what I understand is, patient gets a sleep study, they get a diagnosis, hopefully the sleep study, because sometimes sleep studies are also not that good, but let's not go there. Say it's everything is gold standard and has been done as it should be, and they get a diagnosis. The most common way, not in children they get a surgical removal of that nose and tonsils, and they bounce back. Those children literally bounce back. Their attention span increases, their behavior improves, their development and growth, it all falls back. But in adults, we have to understand where the level of obstruction is. So level of obstruction can be at one place or it can be multi-level. So if it is multi-level, which is the more common scenario, then we cannot surgically correct that. In those cases, most of the patients are recommended to go for CPAP, which is continuous positive airway pressure, which essentially is a device which they wear at night. They need training, they need kind of the whole kit and stuff, which forcibly keeps the airway open. So that was actually discovered in 80s or something as a temporary treatment for sleep apnea, would you believe? As a temporary treatment, and it's 2022. We're still looking for a more.
We're still looking for a better one.
But it works in majority of patients. The challenge is training and how to get on with the machine. The masks are uncomfortable and all that stuff. And I have got nothing against that, because I think we have to clear the obstruction. And if there is something more specific in terms of at one point, then they can get, say, for example, if they got more obstruction in the oral pharynx, which is the back of the throat here, then they can have from the dentist some devices which pull the tongue forward. Unfortunately, those are all other things which you get on the market. If you've got sleep apnea, please don't waste your money on that, because sleep apnea purely is obstruction. It has got so many problems. So it has to be dealt medically. Unfortunately, there's a lot of lifestyle changes we can do, and we'll talk about that just very soon. But please, message is that it is a medical problem, and it has got lots of coexisting health problems. So do not just think it as a snoring correction for snoring. That's different. If somebody has been diagnosed with sleep apnea, they need to work on getting the obstruction, because that's the primary cause of these, all the things which you have discussed. So clearing the obstruction, whichever one it works for them, and the commonest one is CPAP. Now lots of doctors are coming on social media on telling you how to use the CPAP better. So there's a lot more information we're trying to spread, because we are also aware of the pressures of the system. And if we know a little bit more because of our experience, then we're coming here and sharing with you. So please check how to use those masks and things. And I'll never say don't use CPAP, because if your sleep studies are showing clear obstructions, apneas, then we have to clear them. Now, coming on to lifestyle, do you think it's a good point to touch on lifestyle?
Absolutely, yes. So we understand the machines. You can, your specialist can explain more about that. But once you have that machine at home and you do need it, use it. But what can we do besides that to improve our sleep apnea from a lifestyle perspective? So we can have a look at the 6 pillars of lifestyle medicine are, of course, diet, and there is a weight management point there, but it can be also in slim people. So don't think that it's only in patients with a high BMI or overweight. It can happen in slim people. When we look at exercise, the microbiome is a fascinating new study, another thing to touch on today. And of course, stress and management of our daily high workload that we all are dealing with. So let's have a look at maybe from a weight and diet point of view. Is there anything we can do to optimize sleep apnea there?
Yeah, so having a healthy weight is important for our health in general anyway, and it does help people who have got obstructive sleep apnea as well. But then it's a challenge. I find they're not sleeping well, and then when they wake up, they've got more cravings for the unhealthy food, snacks, and they don't want to exercise, because when you're not sleeping well, then it's harder to have the motivation and harder to push yourself to do the right things. So that's why I said, please do use CPAP, because at least then you know that something is working and sorting your sleep out. It may be in the long term, once you have cleared the obstruction through working on your lifestyle. And in mild cases, certainly is a possibility of coming off that machine. But in the short term, I think you have to put the machine on at night so that you have a good sleep. That's important. Now, during the day, I think, working on finding small, things which you can change. Now, when I'm looking at somebody, I look at the place where they can make the maximum benefit, maximum improvement to get the benefit. So if it is diet for somebody, or is it exercise, we just pick up one thing and work with the smallest measure, and then consistently work at it. If I have to pick up one diet, Linda, I would always say plant-based Mediterranean diet, with less fats and less of those things, but more healthier version of the fats, because that has got the most evidence-based. I am myself a fan of anti-inflammatory diet because of the inflammations which we have through different sources living in this environment. I'm not a dietitian, but we all know, and I think there are lots of diets, but there is a lot of debate as well. But there is clear consensus on what is healthy. Now, healthy things are well known, and I don't want to kind of confuse people with that. What I really want to convey the message today, and I'm seeing I can't believe we have nearly spoken for 3/4 of an hour, that there is another thing which we are not aware of, is myofunctional therapy. So myofunctional therapy is essentially treatment for obstructive sleep apnea. Please do continue to wear CPAP while you're doing this treatment. But what it is, it's exercising your upper airway tongue muscles. Remember, the obstruction is happening because there is an obstruction here in this area. And what you're doing with myofunctional therapy is that you are exercising those muscles because the tone has become low. So you are exercising those muscles to get the tone back. So when you have better tone on those muscles, they don't become floppy when they're sleeping. And the second thing myofunctional therapy does is corrects the tongue posture. I know you had Patrick McEwen and other doctors who were teaching about mouth breathing, nose breathing, and how to stop mouth breathing. And one of the commonest things you can do is be aware of your tongue inside the mouth. So whenever you're sitting down, you are paying attention to where the tongue is. And that's a very simple exercise. So normally you would find that your tongue is somewhere sitting either on your just on the base, but you have to roll the tongue and touch the roof of the mouth, and that pushes the tongue up, and that creates the space here. Everything you have to think anatomically in obstruction. So like yourself, Linda, I was a surgeon before. If you think anatomically, you have an obstruction, you have to clear it. So CPAP is one way of pushing the air in and forcing the through the pressure. The other way is increasing the tone of the muscles and changing the posture of the tongue, because tongue is made of muscle, right? So tongue is a big blob of fat and muscle, and it flops back when you sleep. And that's why the obstruction is more, because the tongue flops back and the tone of the rest of the muscles is down. And that's where everything closes. And what we do is make those muscles exercise and change the posture of the tongue, and slowly over a period of time. And there are studies in Spain at the moment where people, even with severe sleep apneas, doing this exercise over 3 months' time, they have found to reverse the obstructive sleep apnea. And they've actually created an app. It's called Airway Gym app, which you can sign up. It's probably £5 or something. I'm sorry, no conflict of interest. I don't know them at all. I just read as you would read. And it gives you, so essentially what I figured out is that it's an app which will work on the phone. And when you're exercising your muscles, it tells you what exercises, it gives you direct feedback. So you're touching the phone. I'm sorry, it's not infection control here, but it's your own phone. And it tells you how much pressure, how much tone is in your muscles, and it measures it. So over a period of time, you're doing the exercise and you're measuring on that app, and it tells you direct feedback. So, people have become very clever in use of technology. And I think, it is now so, I'm sorry, it's not available on NHS, but it's available in different forms. And, it's no harm in using it. It's like a cup of coffee or something on that thing. If you don't like the idea, then YouTube, I think there are a couple of ENT doctors in Royal National Throat in London. They've put in some exercises, and I can share that link with you, Linda, to be shared widely. And you can do those exercises. And it is, sorry, I can't hear you. You're mute, Linda.
This is fascinating. I never heard of the exercises with the tongue before. Could you just have a look at it again? Because I think it's so useful. Even just one simple, without doing too many of them, this one that you just shared, could we share it again?
So pay attention to where your tongue is sitting when you are just resting. Because when you're talking, your tongue is going everywhere. So when you're resting, whenever you're resting, pay attention to where your tongue is. And if your tongue is just sitting on the floor of the mouth, we say just like that, just try to touch the tip of the roof of the mouth. So with the tip, you touch the roof of the mouth. Does it make sense?
Yeah.
And you can feel that, it's coming forward. And use that as an exercise.
And you are pushing, just like with any other muscles, you're constantly just getting a little bit soreness in the tongue, basically what we are pushing for.
Well, we don't want to make it too sore, but you get the idea. Slowly and slowly, if you did it consistently, that it will change the posture. Obviously, if you go and see a myofunctional therapist, they're available as well. They will do full assessment. They will tell you what targeted exercises for your physiology, for your anatomy is, and they will kind of be a bit more specific in your case. Other thing which I like about these exercises is that it also helps your face. And you do not need Botox anymore because it smoothens the wrinkles, because its exercises include the facial muscles as well. So, I mean, that is additional side effect. But
it just shows how these extra exercises actually go against gravitation and open up the cheek, the zygoma, it creates an extra space. That's what we are trying to achieve here.
Yeah. So instead of, getting in through surgery or, forcing through the CPAP machine, you are actually using, a framework to make that, obviously in context of losing weight and healthy eating and stress reduction and not smoking and, not alcohol. Sorry, alcohol is your enemy if you've got obstructive sleep apnea. So stay away from it. So nothing is in isolation. We know that, but it's a useful way of managing this condition. And I only found it because I was looking for lifestyle applications in ENT. And I have really tried to get people to understand in my circles. I think only there's one ENT consultant who's put on YouTube videos, and he's got really good YouTube videos. I haven't found any other ENT doctor who is interested in these sort of things. But one day they will be. Yeah.
Is there any new studies in the microbiomes that science and scientific world that is supportive?
Well, microbiome we know is is one of the keys. We cannot ignore microbiome in any of the chronic illnesses, long-term conditions now, and same in obstructive sleep apnea. But here the link is bidirectional. Before the obstructive sleep apnea develops, now whether that is because of unhealthy habits or whether it's the way your airway is shaped, sometimes you're just born with a narrow jaw with lower airway, narrow airway, and once you develop the obstruction, then your microbiome changes. And then it makes it worse. So microbiome is again in conjunction with everything else. It's not in isolation. So you can use prebiotics, probiotics, and all those things to manage your microbiome in context of a healthy diet. And yes, once you notice that your sleep apnea is improving, your microbiome improves as well. But it's a bi-directional link. It's not that the sleep apnea causes worsening of the biodiversity in microbiome. It's the other way around as well. Does it make sense?
Absolutely. Like everything in life, right, is always bi-directional, and we have to make sure we look at all the pillars, but always start with one so that you have a consistent approach to it. Are there any other lifestyle things that we can do when we are diagnosed with sleep apnea?
So we've covered the 6 pillars of, so diet, physical activity, stress reduction, sleep, toxic substances, community relationships. All these are important in obstructive sleep apnea as well. We've discussed about the current medical management and how we can supplement it with myofunctional therapy by improving the tone of the muscles, by improving the posture of the tongue, and then making sure we recognize that in certain cohorts, the presentations are slightly different, the risks are slightly different, and if it's a high-risk cohort, that means the younger patients with sleep apneas, be it male or female, they're young. In my mind, they're high risk because they have a longer lifespan, and if we're not correcting the things, then they are going to have more of these problems. So I think that's as comprehensive as I can get. Is there anything in particular you wanted to know in terms of?
Yeah, I absolutely love this talk, not just from a patient point of view, but also I learned a lot for my patients as well, to look out for, definitely not to forget children, referral early on, and inform, even if we can refer, inform the parents something to look out for at home. And I think it's such a small but important piece of information for children, and particularly nowadays, to look at presentation of insomnia with women. I thought that was really, really useful. I would love to hear just maybe 3 points that you would like our listeners to take away, that they could, in a summary, that they could use right away to help their sleep apnea.
I mean, I can't believe we have reached that point, which is nearly an hour. First of all, thank you to everybody who has been patiently listening. I really appreciate that. Just so that you know, it's my first talk, so if thank you for sticking it out, because I just feel I'm being brave here, and Linda has been supportive. In terms of the 3 takeaways, so I think the first one I would say, recognizing that different types, not like types of sleep apnea, but in different populations it presents differently. Other important thing is that, BMI alone, so weight alone, is not going to be your marker. So somebody has lost weight, say somebody has been diagnosed with obstructive sleep apnea and they lose the weight, which is great, which is what we want them to. Healthy weight has got lots and lots of advantages, but they lost the weight doesn't mean always that their obstruction has cleared, because it's important to recognize that obstruction is caused by the tongue and the complex, the when you're sleeping, how the whole airway is open or closed, and it's a complex way. It's not just based on weight. So it may take longer for your obstructive sleep apnea than your weight reduction to get better. So weight reduction doesn't mean stopping your treatments. Weight reduction is very important, and I cannot, overemphasize it, but please do not take that as a marker of your treatment. It has to be done by your sleep specialist, looking at the sleep studies, measuring the number of apneas, measuring the number of hypopneas. If they're reducing, they will tell you if you can reduce your treatment, whichever one you're using. Okay, so that's one. The other one, I think, which I've passionately spoken about, is myofunctional therapy. You can look up some YouTube videos. I'll share the Airway Gym. It's literally called Airway Gym app, and you can look it up. I think that's it, Linda, from me in terms of takeaways. That be aware of it. Use all lifestyle pillars, but weight reduction is not just the marker. It's the sleep studies which will help you in terms of assessing the treatment response, and myofunctional therapy. I'm a super fan.
This is so very useful. Thank you so much, Kiran, for joining us today. I have learned a lot, and I hope our listeners did too. If you are new to us on YouTube, do please support our work and hit the subscribe button below here. And if you are here on Zoom, then we are just going to go off to our little chat that is non-recorded, so that we can have a little bit more wisdom from Dr. Kiran Agarwal today. Now, if you want to find out a little bit more about breathing, we have interviewed Dr. Patrick McKeown about how to breathe, and this talk is on the correct nasal breathing and how to stop mouth breathing. It's a very important piece of information here to add, but it's a huge topic on its own. And I cannot stress the importance of such a basic but so important thing that we do every single day: how to breathe correctly, how to position our tongue correctly, so that on the long run we can actually prevent our whole body. So thank you so much once again for joining us, Dr. Kiran Agarwal. We hope to speak to you about a lot of other ENT topics in the future.
Well, thank you, Dr. Mizun, for giving me this platform. As I said, it's taken me a lot of courage to be here. I was hoping somebody else will do it, and I have been asking, hello, Dr. Mizun, is somebody else looking at this? Please, can you tell me? And you were saying, no, no, no. And ultimately I had to come up. You do not know how I'm feeling. I'm feeling very elated that I have been able to share what I wanted to. But at the same time, as I said, I'm a little nervous as well, because it's not
something done incredibly well. And as doctors, we are not taught to public speak, especially not video speak. We teach each others and our patients in a private setting, and it can be, I remember on the first, this is your first time on camera. I remember I started this a year and a half ago, because as we were just desperately trying to get the information out, and it wasn't about us. So because we felt that our patients needed it, we started the video sessions. But you have done amazingly. We just stared at the camera in the first many sessions, because we were so stressed out about talking in front. And now it's a little bit easier, but in comparison, come on, you have done amazingly, and you got the message across. And I'm just so proud to know you as my colleague in the NHS and bringing the information forward. Thank you.
Well, you are too kind to shower me those generous praises. I learned a lot from you as well, and your energy to spread the message that is rubbing on us.
Thank you so much. Well, we are off for the lucky ones who joined us on Zoom. Otherwise, I see you guys next Sunday. Bye.